Today, we have with us Dr. Supriya Kulkarni. Now, Dr. Supriya Kulkarni has many titles. She's a breast radiologist at UMIC. She is the most famous breast radiologist in the world.
So, breast imaging or breast radiology, as you call it, is really very unique, and people don't understand the expanse of what we do.
Okay, fine. Maybe a hospital can have just one breast radiologist, but no. You have an entire division with so many breast radiologists who are needed to kind of take care of the patients.
In order to get to that screening center, you need to go in a boat. Okay. And in the winter time, the river freezes.
Oh.
So the only way to get there is a dog sled.
I understand that there's dedicated breast fellowships, but then there are some hybrid fellowships as well.
Yeah. So for somebody to be able to read a mammogram, a screening mammogram, you have to have 1,000 mammograms per year.
So Supriya, thank you very much for taking your time to be with us today.
Thank you for having me.
Oh, it's a pleasure. One of the things which has always interested me is that radiology began as imaging of the entire body. So there was a radiologist who would take care of everything. And then somehow it naturally got separated into divisions and organs. So we had like head, and then we had body, and then body got subdivided into abdomen, and then we have like cardiothoracic, take care of everything like lungs, chest, and everything included. Musculoskeletal takes care of everything. But then breast radiology is so unique that it's an entire subdivision for one organ. I don't think anything like that exists anywhere else in radiology, because abdomen, whole bunch of organs. Chest, it's again like lungs and heart and all the vessels and a whole bunch of organs. But breast is so unique that it's one organ. Why is it like that, and what makes breast so unique?
So breast imaging or breast radiology, as you call it, is really very unique, and people don't understand the expanse of what we do on a day-to-day basis. So we deal with mammography, screening and diagnostic. We have ultrasound, we have MRI, we have other modalities like contrast enhanced mammography, which is relatively newer. And not only that, we do a lot of interventional work, which involves ultrasound biopsies, mammographic stereotactic biopsies, MRI biopsies, localization. So there's a whole bunch of interventional stuff that we do with breast pathology. Apart from interactions with patients, oncologists, surgeons, on a daily basis. So it is a whole gamut of patient experiences, the radiology work, as well as intense multidisciplinary interactions. So it's like a fully compact ecosystem that we work in. And so that's why it's very special.
Interesting. So it's not as simple as having a diagnostic radiology and interventional radiologist, whereas from what you say, you're like a diagnostic radiologist dealing with all modalities, an interventional radiologist dealing with all kinds of modalities for the intervention of the patient, and then also, first and foremost, a physician in which we're dealing with patients. And it's kind of very unique in that aspect, that it's a perfect blend of everything. But then again, like how it's not... So then when you think about this, okay, fine, maybe a hospital can have just one breast radiologist, but no, you have an entire division with so many breast radiologists who are needed to kind of take care of the patients. So is breast pathology, is it that common? And is that one of the main reasons why we need more breast radiologists in the future as well?
So basically, the reason we need more people is because the volume of work is very high. As you know, we want to detect breast cancer earlier on, and you may have seen this sign, on the road or at bus stops, that 1 in every 9 person will get breast cancer. So we have a very big organized screening program across the province which we are in right now, Ontario, but also across Canada and other parts of the world.
Wow, okay.
So if we expect every single woman to come for a screening exam, that's going to generate a lot of work. At the current time, our screening program, despite of being one of the largest and the most successful programs, only brings in 60% of the women.
Oh,
in
really?
the province, yes. And that's
So
like a national benchmark. Like it's like a provincial number that I'm telling you. So we are still only bringing in 60% women, which means there are 40% women who don't show up. And despite of that, we are really overloaded with work because each person will come in once in 2 years. And that generates a lot of work. Not only that, the incidence of breast cancer is related to age. Age is the biggest risk factor for developing
Okay.
breast cancer. So as women grow older, they get breast cancer. And so we have a high, and it is one of the commonest cancers in women.
Okay.
And we know overall there has been an increase in the incidence of cancer in general. But we are also seeing an increase in the incidence of breast cancer in younger women. So there is a lot of work out there. And for us here specifically, we are running 3 different centers within UMED. So we have 3 different hospitals, so which means we require multiple people to cover all the services. So it's very busy.
So you're potentially saying that 40% of women are still not covered. And
Yep.
what would you say would be the best way to kind of bring those people in the fold as well?
So, the organized screening program is run centrally. So it's not even like that we are running our screening program.
Absolutely.
It's a provincial screening program, and they do everything possible. But it's so many things: access, different communities, lack of knowledge. It's just the facilities, and it's pretty incredible. Like, we can get people to come in.
There were, back in India, there were these buses in which they would go to these rural areas and do it.
Yeah.
Is that something you think would be helpful in our
very
setup?
interesting, because people don't understand the Canadian landscape. So, for example, here in Ontario, if we just talk about our province, if you go to Sudbury and north of Sudbury, there's very poor access. And just an interesting fact, which I actually also presented at RSN and people were like blown away, is we have a small OBSP. OBSP is our screening program, Ontario Breast Screening Program, in a place called Moosonee, which is in very north of Sudbury.
Okay.
And that place, in order to get to that screening center, you need to go in a boat.
Oh, wow.
Okay.
Okay.
And they don't have any diagnostic facility, so they can't do biopsies or any other thing. So just imagine how many women actually make that effort to take a boat and go there.
Okay.
And in the winter time, the river freezes.
Oh.
So the only way to get there is a dog sled.
Oh my God.
So
Okay.
I just want to explain how access is important, especially in just geographical access. I'm just talking about geographical access here. So in that area, recently, we actually did get approval to have a bus. There are other buses that run in that region.
Okay.
But specifically for this particular cancer regional program, we are actually working on getting this bus for us. And that bus is going to be equipped with the most state-of-the-art mammography equipment, which has tomosynthesis,
Okay.
which is kind of, it's like a mammography equivalent of a CT.
So you have thin slices.
So we have thin slices.
throughout the
It's
breast.
not 3-dimensional, but
Yes.
still, we have a tube that rotates. So we're going to have that on the bus. So to answer your question, yes, in Canada, there are many places where we do have mobile buses, but they can be buses because of the weather. It's actually it's like a container truck kind of a situation, because we have to be able to go across different terrains in the winter time.
That is fascinating.
So, yeah,
because
it's very, very intriguing, this whole geographical access situation.
Because I always thought about the width and breadth of Canada, but it never factored in the climate as well, like winter and snow, and that actually causes additional barriers throughout. Yeah, so that's really fascinating.
So, places like Nunavut and these areas, they don't actually have any screening programs in place. But there are facilities. For example, a hospital in Ottawa provides services in the remote area. So they have a radiologist fly in there occasionally, but they bring the images here. So it's very intriguing.
Yeah, so it's one thing that, in the middle, because most people are trying to get their work done on a day-to-day basis, make their living, spend time with their loved ones. So it's one thing if you kind of have to pop into the hospital for half an hour, get it done and come out.
Yeah.
But if you have to make this extra effort to kind of go through the snow or make a huge trip just for this, and then you are expected to do this year after year after year, then I understand it becomes a challenge.
Yeah.
But then the other thing which I was thinking of is that in addition to having a mammography, let's say even if you did have mammography units there, it doesn't really stop there, right? Because I understand there's a recall rate and you might want to do an ultrasound as well. So how does ultrasound fit in all of this in your practice?
So when we find any abnormality on a mammogram, or if there's a palpable finding or you want to do a biopsy. So ultrasound is very easy and easily accessible.
Okay.
So we use a lot of ultrasound in breast imaging. It's like our next modality once the patient has a mammogram,
Okay.
before we move on to anything else.
Okay.
So ultrasound is very integral with the diagnostic ultrasound. Let me clarify that.
Yes.
Is very important for workup of clinical scenarios in breast imaging.
Okay. So after mammography, if you identify something abnormal, you bring the patient in for ultrasound.
Yeah.
An ultrasound may be normal, may be abnormal.
Correct.
So even after they make the trip to go and get this mammography done in a rural area, they might still be expected to come in. And at that point of time, they have to come into an academic center with somebody with expertise, which I understand ultrasound is very user dependent, right?
And if you look at again the landscape, most of the screening mammograms are performed outside academic centers.
Okay.
So they're called IHFs, like clinics. We know them commonly as. So most of the mammography is performed at non-academic centers because we can't bring everybody into a hospital for a screening mammogram. We do more stuff in the hospitals than just screening. So all the recalls that are generated at the level of the IHFs get dealt with at the level of the IHFs. And from there, then work starts to filter in to academic centers. We were talking about consultations just before we started. So that's where the consults kick in. Once somebody has done something outside, then the case comes to the academic centers. So almost all the clinics that do mammography also have ultrasound.
Okay. So most of them have ultrasound expertise
And
there.
they may
so-
not have a radiologist on site.
Okay. So it's
this
done
is-
by technologists and
This is
then...
the one area of imaging where we are heavily dependent on technologists because the mammography is done by the technologists.
Yes.
Ultrasounds are done by technologists. And there is a special training required for a technologist to be doing mammography or ultrasound.
Okay. So that is kind of very heavily
Very
regulated.
integral, yeah.
That's amazing. But what about training for radiologists? Is breast imaging integral in radiology residency curriculum currently?
Yeah. It is integral in all radiology curricula. Our residents would go through 3 to 4 rotations during their residency program. For screening mammography, in general, number is very important. So for somebody to be able to read a mammogram, a screening mammogram, you have to have 1,000 mammograms per year.
Every year?
Every year. That's a annual requirement for you to be qualified to read a mammogram.
Wow, that's quite a high number.
Yeah.
1,000 mammograms is quite a lot. So it means that you need to be in the mix and keep doing things.
1,000 is actually a lot, and many non-academic settings, people may not reach that target. So that's like a whole different story. But coming back to the residency program, we require them to read a set number of mammograms. It's like 600, I think, currently.
Okay.
So even the residents, they need to maintain a log to document how many mammograms they read, how many ultrasounds they read, how many MRI. So each program will have their requirements, like we have our own at U of T, and they need to meet that criteria. And sometimes residents who don't achieve then have to miss some other rotations, have to come on their vacation days to finish their numbers.
Wow,
But
that's
a mandatory
interesting.
requirement, yeah.
Because that's not the case for any other imaging part. I know for prostate imaging, they were considering doing something like that, saying that, hey, an annual requirement of like 200 MRs or something like that.
Yeah.
But it never came into guideline because it really wasn't feasible. But it's amazing that for breast that the quality control is so integral. So once they finish their residency and they become radiologists, let's say they want to be a general radiologist, do you think that's sufficient for the most part? Or do they need to find additional training?
You know, most radiologists that go out into the community and do a little bit of everything, they mostly would do it on the basis of what they've done during residency. I personally feel that's not enough.
Okay.
Because breast imaging has a lot of complexity and is very user dependent even when you're reading. So,
So it's not as simple as looking at it and identifying. It's going to be...
No. People run into a lot of problems and then they will reach out and find out what to do. And because there's so many modalities and so much work even out in the community hospitals, and they're dealing with complex cancer cases. Most of them managed. That's what people are doing.
Uh-huh.
But most people would go in for a high impact fellowship if they really want to do breast imaging as their like a majority of their work, or that's going to be their only work that they're going to do.
Okay. So, do you think that, like, if you don't do a fellowship, are you going to be overcalling or undercalling cancers? Are you going to be missing cancers, or are you going to be calling back more patients, or is it both?
It's both, actually.
Okay.
And frankly, it's not even, I would say that breast imaging is something that we should know that missing cancer is not always a radiologist function. There are many reasons you cannot see a cancer.
Yep.
And it gets called a missed cancer. And when you say missed cancer, people think, oh, this person missed it.
Okay.
It's
okay.
not like that.
It's sometimes a function of the modality itself.
There are many reasons. Like we have conferences on what are the causes of cancers that are not detected on screening. So it may be occult, the breast tissue may be dense, there may be calcifications that look benign but are malignant. So there are like many ways that cancers can present, and there are many ways that cancers may not be seen on screening. Yes, interpretation is one of the ways that
Interesting.
may lead to a delayed diagnosis, but that's not the only reason.
Okay. So it's
Yeah.
so when you're fine tuning your skills, it's not just the diagnostic interpretation; it's also what to do next in each scenario.
So, for example, the cancers that you miss on mammography are different. Those that you miss on ultrasound are different. The ones that you don't see on MRI is our most sensitive tool, yet may not pick up low-grade DCIS, may not pick up invasive lobular carcinoma. So it's like very pathology-driven.
That's very interesting.
Yeah.
So in fellowship training, and that's when you get all fellows to hone their skills, I understand that there's dedicated breast fellowships, but then there are some hybrid fellowships as well.
Yeah.
Is there any difference in how they're approached?
So generally, you would want, if you want to be called as a fellowship-trained breast radiologist, you require a minimum of 6 months of breast imaging. So we have these body breast fellowships even at U of T and other places in Canada. We have those modified to have 6 months of breast and 6 months of body, just so that people who finish from here can call themselves breast-trained radiologists.
Okay.
Doing 4 months, 3 months is not enough.
Okay. So you think that at least 6 months is needed, but would you recommend 1 year generally?
Yes.
Okay.
Yes. And I've seen that many of our radiologists who do this breast body combination, like I did a breast body fellowship as well here, you need 6 months.
Okay.
And they, even after 6 months, they feel, oh, they need a little bit more.
Okay.
Almost always they feel they need more breast rotations. And so they would give up, some of the rotations, like, for example, OB rotations or, some non-mandatory rotations in body to do a little bit more breast.
To get comfortable with that.
Yeah.
That's amazing. And when you have trainees come in, not just fellows, but even residents, because breast is usually not the first block they're doing, right? It's always body or neuro or something. And then they come to you. What's one thing you find that they're very surprised about with breast?
Now that you ask, this is a very common occurrence that residents show up for breast rotations. By the time they come to us, they've already selected their fellowship programs.
Oh, really? So
Yes.
they come quite late.
They come late because it doesn't happen in the first couple of years. And almost always I say, oh, we didn't know this was breast imaging. I would have probably chosen something else. Or I would have chosen, instead of body, I would have taken body and breast, and this is so good. And so when I find such people who feel inspired, I spend a lot of extra time with them because I know they will be going out into the community and doing breast, and that this is our only chance to work with them.
Okay.
Because they're going to go into some other fellowship and then out.
Yes.
They may not. So some of these people actually, when they get their jobs, they come back to spend time with us before they start the job.
That's amazing.
Because,
Okay.
for example, somebody may have done a body fellowship
Yes.
and has a job which will require them to do breast, which is the case almost always.
Yes.
So they would come back after their body fellowship to spend like 2 weeks, 3 weeks. I've had people who've done intervention and come back for a couple of weeks
Okay.
just to, get that
Get the hang of things.
hang of it. So that's very common. So they get very surprised how, people think breast imaging is binary.
Yes, cancer, yes
There's
or
a
no.
cancer
Right?
or there's no cancer. But people don't know that there is so much stuff in between. So that is the thing that surprises trainees the most.
And what happens when you kind of find these intermediate thingies, and how are these newer modalities? So you're talking about like tomosynthesis as well as the contrast
Yeah,
enhanced
yeah.
mammograms, and how have they changed the landscape of what we're doing for patients?
So we are seeing more things earlier.
Okay, which you think
And
is going to be good.
these earlier things are not necessarily cancers. So
Okay.
that's what we call them as false positives on like in breast imaging. It's a big controversial discussion about how breast imaging detects so many false positives and how it stresses out the patient and it's harmful to the patient. So we see more things, but we also see more cancers.
Yeah.
So for any new modality to be effective, we need two things. One is increased cancer detection rate,
Yes.
which is your true positives,
Yes.
and reduction in the recall rates,
Yes.
which are your false
False
positives.
positives,
So
yes.
we need both of them to be impacted. So tomosynthesis has that effect.
Okay.
And the other new, like MRI obviously is highly sensitive,
Yes.
but less specific,
Yeah.
which means this is how I explain to the patient that, which means we will see more things, but not everything we see will be cancer. So we're going to end up following them.
Okay.
Or we may end up biopsying them because these women are under high risk programs.
Interesting.
So that is where the nuances come in. Who should we biopsy? Who should we follow?
Yes.
And on follow up, is the mass going to grow? So all these things are very difficult to explain to forget trainees, to the patients.
Yeah.
Right. So these are the conversations which really surprise many people who go through breast imaging, like how much we need to explain the limitations of our imaging.
Wow.
People
That's
don't
interesting.
understand.
So MRI, you're saying that it'll pick up more stuff, but they may not be
Yeah,
cancers.
this is like my standard consent for MR.
But tomosynthesis, you think is the best for.
No, it is a better way of doing mammography.
Oh, so do you think that at some point of time, all mammographies should be phased out in and do tomosynthesis instead?
It has already happened. Many
Okay.
centers are doing tomo as their
As the first
primary screening modality.
Oh, so why is it not more widespread? Is it the cost?
Cost. And one of the things with mammography is people don't realize that we have a lot of standardization. So every year, each facility and technologist has to submit mammography images for accreditation.
Okay.
It's called the CAR MAP program,
Okay.
the CAR mammography accreditation program. So, for example, if I'm at Sinai, I have to submit every year images that are like the most perfect images that you could take to make sure that we are meeting the standards. So with what happens is when you have a new modality, then they have to figure out what standards we have to establish for the new modality.
Okay.
So they went through this whole iteration about tomosynthesis, and now we are allowed to submit tomosynthesis images for accreditation.
Accreditation as well.
So with each modality, they have to figure out what is the standard.
Wow.
So it's a very heavily kind of curated, modality where everything we do is measured.
That is amazing.
Everything
that
is measured.
Yeah, you get feedback for
Yeah.
everything, and
Yeah.
it's like very, very
Yeah,
accredited.
there are standards of how to take ultrasound images, what to document, how to label abnormalities in the breast, the clock position. Like everything is like standardized.
And what about contrast enhanced mammography? Is it contrast injection and then doing a routine mammogram? Could you do a contrast enhanced tomosynthesis then?
It's in the pipeline. It's not
Okay.
yet available, but definitely the companies are talking about it. So
Is
in
the
breast
contrast
imaging,
same as the CT contrast?
yeah, it's the same CT contrast, but off-label
Uh-huh.
because it's not kind of approved for mammography.
Yeah.
But it's the same contrast that you have CT with. And any vascular imaging modality always trumps any just mammography-based technique, right?
Okay.
So the best one we have is MRI.
Yep.
But then there are so many problems with MRI, most importantly, access,
Yes.
magnet time. So CM is like the next best thing now.
That is incredible.
Yeah. So it is a vascular technique. So it is far superior than ultrasound, far superior than standard mammograms, and far superior than tomosynthesis.
Wow. Okay. So now we have all of these weapons in your arsenal, and then we need to figure out when to use what and how to
Yeah.
use it, how to
Yeah.
kind of standardize it. And
Yeah.
I understand that kind of causes all of the
Yeah.
necessary time to become good at it, right?
Yeah.
But you said that interpretation is one part, and then we also spoke about all the modalities and then how to kind of divert the patients. But then you also spoke about how you're talking to patients and discussing with them and stuff like that, which is very unusual for radiologists to do in any field, because primarily our job is to give the report and then the clinician deals with it.
Yeah.
So why does it not happen that way in breast, and why are breast radiologists very involved in patient care?
So the most important thing is we meet patients before they meet their physicians.
Okay.
So if let's suppose I did a screening mammogram, patient is asymptomatic, so obviously they have not met the doctor.
Yes.
And then we find something, and then we call them back. Then we do a biopsy. So we are seeing the patient multiple times before they get to a surgeon.
Okay, so this is not coordinated through the family physician.
No, because once the patient comes for a mammogram, then we kind of take over all the recalls, the biopsy appointments, depending upon obviously facility to facility. But generally, whoever finds the abnormality, that facility calls people back.
Okay.
Especially if it's an academic center where we have biopsy facilities.
Yes.
And so we are actually seeing the patient before the report goes to the surgeon.
That is,
So we are the primary physician who's talking to the patient, telling them what we're doing, why are we doing it, could this be a cancer, what happens next. And it's incredible how much time and information comes through radiologists than the actual physicians. I've had patients who are going to surgery the next day and don't know what's happening tomorrow. So then you end up talking, oh, you're going to do this, then you might meet an oncologist, and you might have radiation oncology, then, so it's like a whole package. And we spend a lot of time talking to the patients and we not only patients, their families. So this is you could end up spending an hour with the patient, including their procedure, their consent, and all the talking and the anxiety. It's one of the things that you really see the impact of what you're doing on patients.
is it also like a very emotional thing in general?
Yes.
Compared to
Because, if you're going to tell somebody that you're going to biopsy a suspicious mass, that changes their whole life. And you're the only person who's standing there while they're dealing with all these emotions. And they're lying down and they're going through this whole, what's going to happen to their families, their children. There's like so much stuff going on in
but
their
also
head.
the visual aspect, right? Like there's something inside the liver. They're like, okay, fine, it's just hidden. But I think that there's also a possible stigma associated with it to a certain extent.
One of the reasons you were asking me why people don't come for mammography is the fear. I'd rather not go to find out something. They're going to call me back. And it's also been seen that people who get called back are less likely to go back for a mammogram.
Okay.
Right? It's just how the mind works.
Yeah.
It doesn't make sense, but that's what happens to people.
Yeah, I kind of see it because you get called back and then there's like couple follow-ups and then you say it's nothing. They're like, oh, these people, they're calling me back too often, and then you don't go.
Do you know sometimes physicians show up for mammograms and they think you see that they haven't come back for 3 years because they're busy.
Yeah.
They don't even realize how time passes. I said 3 years, so that just happens to people.
Yeah, so I understand you've done amazing aspect of taking over the care of the patient yourself as radiologists, which is unusual in any other field, which is incredibly important to get it to this level. And that you've, despite all of this, there are still lots of gaps which needs to be addressed and which can always be improved.
And even anger. We are there to experience the brunt of the anger because they are so angry. Like, I did everything right. Why would this happens in a lot many younger women and people who are high risk and have had mastectomies, yet they develop breast cancer. So we are there to face like all kinds of emotion. And if we are not equipped, then it becomes very challenging. The work becomes very challenging.
Is this something you train your trainees as well?
I like to spend a lot of time emphasizing the importance of appropriate communication. I wish we could put together like a course, but just how to consent, how to make sure that they understand the limitations, how to make them understand that sometimes we biopsy and it's a different area.
Yeah, the biopsy,
Right?
like you can't be
You
100%
can't-
accurate.
yeah.
There's always going to be like biopsy
And then,
errors.
like for example, the breast MRI is performed when you're lying prone. Ultrasound is performed when you're lying supine. Mammography is done when you're standing up. So it's like an ice cream cone example I gave them. Like, it's like holding the ice cream cone upright versus upside
This-
down.
okay.
So it's very difficult to coordinate. And to make the patient understand that is very
Yes.
difficult because you did the MRI, you should know where to go. What do you mean you're going to put a clip to find out if you biopsied the right area?
Yeah, yes.
Like, it's very difficult to explain to patients that.
That's very interesting.
Yeah.
And now with we have all this AI coming in, how do you think that's going to impact anything in the future? Do you think it's going to make things easier or?
Did you read recently? There was like a very inflammatory report in one of these, radiology business type of that somebody in New York, the CEO of New York, one hospital in New York, said that he's ready to replace
Yes.
radiologists with that led to like a lot of discussion.
I was going to ask you that. Exactly. Yeah.
And,
so essentially, the quote was that he was ready to replace breast radiologists. And I think it was kind of specifically breast
Yeah.
radiologists with AI because he's like, that's that good.
Yeah.
Do you agree?
I don't think AI is there right
Okay.
now to even think about replacing radiologists, although it is a very good triage tool. The most important function right now that it's serving is triaging the low risk versus high risk cases.
Yes.
So that allows changing your workflow. So, let's suppose I'm most productive in the morning. So then I would read all the difficult cases in the morning because AI has triaged it out for me.
Yes.
And then the low risk, cases I would read like after lunch.
Yes.
There are reports where they're saying now that the low risk cases, maybe you don't even need a radiologist to look at it. But we are not at that phase yet because we don't know the legality involved in the whole of this thing because breast imaging is a very medico-legally sensitive branch as well.
Yeah.
But it's a great triage tool. It provides a great second read. We don't have the system of second reading in Canada, but many European countries do double reading for mammograms.
What does
so
that
two
mean?
radiologists will read the same mammogram
Oh, wow. Okay.
independently.
Oh, they wouldn't have each other's reports.
No.
So what happens if there's a discrepancy?
Then the third radiologist comes in.
Oh, wow. Okay.
Yeah.
So there's a third,
Yeah.
and that person will have both reports
Yes,
and then he'd decide.
Yes. So we don't have that system. So for
Why do we not have that system?
we don't have a capacity to read first read.
Okay.
Okay, forget second reading. So I find personally using AI to read screening mammograms provides me a second read.
Absolutely. Okay.
And it makes it so much easier and faster to read mammograms when you have an AI tool accompanying you.
Yes.
So it's a great tool as a second read. It's a great triaging tool. So it's a supportive tool. It's not necessarily a decision-making tool, right?
Yep.
So it's a very good supporting tool. And of course, AI has other applications in breast imaging. Like there's AI for technologists. That AI tool will tell them if their mammogram is adequate or not. Where is the shortfall? Which area did they miss? While the patient is still there.
Ah, okay. Interesting.
So that's a very important tool. And then we have risk assessment tools. So breast imaging is all about risk. Like what is your risk of developing breast cancer? A risk of a 35-year-old and a risk of a 45-year-old will be different.
Yes.
And as the patient ages, the risk changes. So it's very dynamic. So if you want to offer personalized screening, you need to be able to calculate the risk fast. So one of the applications of AI in breast imaging is for risk assessment. That's like very powerful. So it allows you to personalize the screening intervals.
Yeah.
And one of the things I always discuss is we perform screening to detect preclinical cancers. Cancers that are not clinically apparent, cannot be felt because early detection saves life. When we use AI, we are detecting pre-screening cancers.
Oh, wow. Okay.
Do you understand?
Yeah.
Which means AI has flagged something that we don't see. So how do we work those patients up?
Yeah.
Because we don't have AI biopsy tools,
Yes.
right? So AI is going to help us detect pre-screening cancers.
Yeah.
So if an AI flags a person's mammogram and you don't find anything there, then those are the patients that you're going to offer enhanced screening.
That's very
So you
interesting.
might screen them more frequently. You might screen them with a vascular modality like MRI. So those are the patients who we are going to focus our attention on more. And so in that sense, we can personalize screening.
Oh, that is amazing.
Right?
Because in my mind, I was thinking of more
Mm-hmm.
of initially what you said, in which, positioning is bad, you can change it. Or if maybe the breast density is too high, it can just detect
Yep.
and say, hey, wait for an ultrasound on
Yeah.
the same day. But what you're talking about is that it may have the potential to identify things much, much earlier.
Yeah.
And not just that, in risk assessment, now we have more of these NGS, the next generation sequencing. We have all these genes. We all know about BRCA1 and 2. But there could be other genes which are affecting in a small
yes.
minor variant.
Yes.
And once you have entire genetic sequences identified for individuals, you can throw that all into AI models and then have risk
Yep.
prediction tools and then identify them as early as possible, which is incredibly fascinating. And is that what the role you envision?
Yeah, I
breast
think it
radiologist?
has very, very use. And now we have imaging-based AI risk assessment. So I could use a mammography image, and based on the like radiomics, you could generate risk assessment based on that image, right? So like the density, because it allows us to see the tissues in a different way, as opposed to visually saying, okay, this is a dense breast, so this person has increased risk of developing cancer. Not every dense breast has the same risk, right? Yes, dense breast hides cancers. That's why we miss cancers. But dense breast also increases the risk of cancer. So we have tools now, and they're still experimental, obviously, which can help you assess risk based on the density, based with AI. And similarly, we have radiomics with MRI. We can actually look at the tissues and assess, is this cancer going to respond to chemotherapy? We can predict it ahead of time. So that's where I find is going to be the more clinically impactful role that AI would play.
So, finally, what advice would you give? Especially because there are some CEOs saying, and I think that this is something which I kind of want to touch on AI as a whole. Currently, we are still in the 90-10 issue, in which AI is good for 90% of the stuff, but 10% of the stuff, it's kind of bad. And then how do you kind of determine which is the 90, which is the 10? Like, for example, we've been promised self-driving cars for so long, and it's nowhere close. But let's say that even if we do solve the problem, I think what we fail to understand is that as physicians, you are not as good as we were back in the 2000s. Things have evolved so much. We're getting better and better and better and better. And as you're talking about, we moved from detecting like huge palpable lumps to kind of detecting preclinical cancers and pre-screening cancers and trying to prevent even development of cancers down the road. So with all this in mind, that we have this conflict that humans naturally are evolving to become better, but then you have other entities who are saying that, hey, they need to become obsolete. And now you have trainees in the middle not knowing which side to kind of rely on. What would your advice be for a trainee?
Very interesting. I don't know if I read it somewhere but I can say that one thing, that AI will replace radiologists, those who do not use AI. Right?
Yeah.
For all of the AI tools that are being created, who's going to do the validation? Right? Ultimately, the validation is performed based on the images we have.
Yes.
And we need to continue to have these large data sets for AI tools to develop. So who is going to be reporting all those large data sets? So yes, AI will replace only those who don't use AI.
Absolutely.
And I've been talking to quite a few imaging leaders here in GTA who, we meet up at different places. And I said, if you want to retain your radiologists, you're going to have to provide them with AI tools. Otherwise, young people will not work.
Absolutely.
Right?
Yeah.
And so it's a way to retain people. And so we should be working with AI tools because they definitely improve efficiency and workflow and helps people to feel more secure, especially if they're not fully trained in that particular modality. So AI is nowhere close to replacing anybody. So trainees should not think that I don't want to go into radiology because AI is going to replace me. That's never going to happen. At least not in the near future. And ultimately, you require humans to make decisions because, at the end of the day, they're going to see surgeons and other treatment options. So we will always need a radiologist.
Yeah.
I don't think anybody should be using AI as a consideration for skipping radiology.
For a career choice. Absolutely. That was really well said, Supriya. And the other thing is that like when AI, even at some point of time, if it is as good as us, but as human beings, we are always better than yesterday, or we're always trying to do things better than yesterday. And that's kind of why we need more breast radiologists. Because maybe 10 years down the line, AI is as good as we are today, but we're going to identify cancers early. There's going to be always innovation in everything.
Yeah.
And medical field, as opposed to kind of like driving or something, it's ever improving. It's always like mortality rates and everything have changed so much over time. And there's always going to be need for people with niche interests and specialty to keep pushing the field further and further so that we can do better for our patients.
Yeah, absolutely. And every iteration of AI will require an FDA approval.
Yes. So there are legal challenges involved.
So, I mean, it's not like you have an AI tool and it's in clinical practice.
Yeah.
There is always going to have to be validation. Even the ones that we are using right now, the minute the next version is released, it's going to require FDA approval because it's a different tool.
And then let's say it's better, then we'll try to do something better to make it better. And it's kind of a perpetuating cycle.
It's just how it is.
Absolutely. Supriya, it was such a pleasure having you here and speaking through the entire gamut of breast imaging and what makes it so special. Thank you very much for all you do and all the education you provide for not just not just for your patients, but also for radiologists around the world. Thank you very much.
Thank you for having me.